Hello everyone, this is Louis Brennis. Welcome to my health lesson evaluation for my health lesson, Keep Moving for Health. Your quality of life depends on it. This is for American University, Master of Science in Nutrition Education, HPRM640, Nutrition Education Methods 2. The agenda for this presentation is first the introduction of the lesson evaluations, followed by the description of the evaluation design, the data collection, analysis, and interpretation, and finally the communication, reporting, and evaluation management. All right, first of all, the introduction. The evaluation purpose is to evaluate the effectiveness of the Keep Moving for Health intervention, and that's in educating and changing perceptions of risk about a sedentary lifestyle and motivating physical activity in elderly adults at Sunrise Living, Assisted Living. The stakeholders for this lesson were the health educator, the Sunrise Living staff, and the participants. And this was held in a small classroom, or actually activity room, with a small number of participants from the assisted living at Sunrise. All right, this slide here is quite a busy slide. It does cover the resources, activities, outputs, short-term impacts and long-term impacts. Overall, the resources that were used were printed materials, projector, and handouts for reference information for the students. The activities consisted of hands-on surveys, basically hand surveys by hand, of them responding to questions that I laid out for them in terms of their level of understanding or perceived risk or level of activity or physical activity. Some of those outputs for them were regarding the goal setting templates that I provided them, and also being able to have that self-efficacy in terms of the constructs, as well as the actually the activity guidelines is also part of the outputs, and some additional reference materials. So I was jumping a little bit ahead to the short-term and long-term impacts and outcomes. So there, overall, what we're trying to do in this lesson is to have participants be able to define the sedentary lifestyle and basically gauge their perceived level of risk. We want to move the risk forward so that they perceive that there is a susceptibility on their part and vulnerability for their health if they do not modify their sedentary lifestyle, either by reducing the amount of sedentary lifestyle or by increasing their level of physical activity. In this case, sedentary, basically, I have defined it from research as generally meaning anything that is basically not more than just activities of daily living is basically a sedentary lifestyle, such as getting dressed or cooking food and things like that. So participants should be able to develop those skills, those knowledge, those change in attitudes, as well as feel competent in being able to perform these activities, as well as having a sense of self-efficacy that they can succeed in performing these activities. The overall lesson was attended by at least one or two organizers that came in and out during the presentation. So what I had was the information that they provided me about the participants. which initially was mobile participants, but I would say half were immobile. So that presented a challenge for the lesson. All right, so part of the evaluation design for the lesson is conducting a process evaluation. So in this case, we want to evaluate on a few levels, one of them being fidelity, as well as activities and reach. And really we want to say fidelity-wise, how faithful was it to the design of the implementation of the presentation. So if it was implemented properly, then we can gauge whether the success or lack thereof was in any aspects that may have been modified or that were inconsistent fully with the lesson plan. In terms of the activities, basically determining if they started or ended on time, and really getting some of the perception of the audience, the participants, to see if they thought they were of low or medium quality. A lot of these observations are basically reporting and self-assessments from the participants, as well as self-assessments on behalf of the health educator, being myself, and by Sunrise staff. So, and reach, also determining whether the lesson reached the participants it was meant to reach. And as I mentioned, it was primarily geared towards mobile residents, but since immobile residents showed up, may not have reached all of them, which would be modified in future lessons because it wasn't primarily geared for them as originally planned. Again, the reach would be captured by attendance sheets and as well as participant feedback forms if they were aware that the lesson was available and how effective that was. Because there were flyers that were provided. All right, the other process of the evaluation design consists of, for the process evaluation, is in terms of context, dose delivered and dose received. The context being basically what, the context of the environment that the residents live in, being organizational, community, social, political, or any other situational issue that may have impacted the implementation of the lesson in some way, shape, or form, or its outcomes. Again, the assessment forms being something that would be used for gathering the data and also basically reporting back about the status of what was reported. The dose delivered is basically the extent to which the units of each component were provided in terms of the design of the lesson, and there would be a checklist to determine that it was. And so if the two marry, then you could consider the dose delivered provided. And then also that would provide whether the full extent of the material that was intended was covered or not. So the resources for those would be the health educator as well as the Sunrise staff, evaluating on their side and educator side. Dose received is basically whether the participants were engaged in the activities as intended and as provided, and whether they reacted in or had a specific reaction to parts of the lesson. Those would be captured with the checklist, as well as observations of participants themselves. It could also involve engaging participants and asking them more fully what they're perceiving about the lesson so far. All right, assess constructs of the health belief model and social cognitive theory in relation to the advanced age of the participants. These participants are 65 to 100 years old. The constructs that were utilized for this lesson include the perceived health risks of a sedentary lifestyle, as well as the perceived benefits of reducing sedentary activity and increasing physical activity, followed by the self-efficacy, as I mentioned, about engaging in the activity and the behavioral competence in performing it. So in the studies, a lot of the research that I did seemed to indicate that most of the instruments focused on health risk factors rather than actual perceptions of risk. There's some that did not, and those were the ones that I tried to single out here. One of them being one that we have seen before, Behavioral Risk Factors Surveillance System Survey. We've seen the youth version of this as well, and that was gauging a perceived risk for developing stroke among older adults. There was also an interesting one with the Physical Activity Readiness Questionnaire. So that actually, with regards to pain modulation, it presents a clear and present reason for patients to want to engage in physical activity to reduce their pain. So that was interesting to see as well. And readiness covers basically that they are physically ready to do the work that's required, as well as mentally feeling ready to do so. The 38-item expectation regarding aging, that also was another survey that was done regarding attitudes. And all these surveys, sometimes they have abbreviated versions of themselves. So there is an ERA 12 that is a shorter version of the ERA 38. And the questions basically vary by domain and whether they are questions that are positive or negative worded, and how they build up to those questions within the survey. So you can have a lot of questions or you can have less questions depending on the application of the survey. Finally, the Aging Perceptions Questionnaire, that is part of the Irish longitudinal study on aging from Trinity College in Dublin. And so those also gauge perceptions. And sometimes other questionnaires that I saw included even perceptions on the psychological and mental health level in terms of depression or anxiety, or basically negative feelings about aging and how that was affecting folks individually. So all of these I thought were very interesting to read, how they can all be gauged, and the differences also in genders between men and women with regards to their chronological age versus perceived age, which tended to be higher for women on terms of how they perceive their age versus men, and it seemed to catch up later in life towards 70s and 80s. All right, so of all those designs and instruments, the one that fit best was from Hayslip et al. And that team developed new scales for assessing the health belief model constructs in adulthood. And that is young adulthood and older adulthood. I focused on the older adulthood, which they did, and they overlapped the age range that I needed, 65 plus. And the constructs that they covered, scales for included perceived susceptibility, expected benefits of exercise, significant others in support of exercise, and cues to action. So all of these should be familiar. Out of each of these constructs, they had a variety and of number of questions that they created. Again, a combination of positive, negative, and they rated them, each of these, in a 5-point Likert type scale. You can see some start from low to high, some start from not influenced to extremely influenced in terms of the support, social support one, or they begin with disagree and go to agree. So It depends on how the survey's sections are being organized, but you could see that they're all based on that Likert type scale here. One thing, during the lesson to assess the level of physical activity currently being done by elderly adults, again, it was show of hands during the actual lesson. There are, though, some instruments from research regarding that, and I listed some of these here and selected one that I thought was a good fit for this lesson. So the ones here listed, the PASE Physical Activity Survey for elderly adults, and all three of these are for elderly adults. So that one was the most common, but it is limited with what it captures and lack of sedentary time. And the type of activities it listed were generally those for folks not in an assisted living home, such as gardening or landscaping, things like that. But it is a short survey, so that has the advantage of being able to complete quickly, especially if the lesson time frame is time bound. The Yale Physical Activity Survey was the one I thought was the best fit in terms of a model. It's also very common. It's similar to the PACE, but it actually does capture what the PACE does not capture. That's why it takes a little longer, because it's capturing the sedentary time as well. But it is particularly pertinent to assisted living activities as well. And then the CHAMPS one is kind of a newer one. I saw less studies on that, and it's intended to capture those outcomes of a community intervention, basically, for physical activity. So not necessarily just to fully gauge the level of activity. But that one takes about 15 minutes to complete, so it's basically halfway between the two surveys listed here. So again, I would see this lesson being evaluated on the constructs and also on the physical activity level. All right, so in terms of data collection, analysis, and interpretation, so Hayes-Lips questionnaire, and that one was regarding the constructs. So this one, according to their research on 60 to 91-year-olds, median age of 72, it had a pretty high coefficient alphas for each of these constructs, as you see listed here. They were also contrasting young versus older adults, and any kind of analysis within that, but I just focused on the older adults group. So as you can see, each it's well above the 0.80 requirement, or minimal, I guess, the good requirement for that level. So this is a pretty good instrument. Also, the validity method that they used was a one-way MANOVA by age groups to detect any differences. So with regards to that, the data collection for that would also be, like I said before, a questionnaire that the participants would do during the lesson, during an activity break. So about 4 activity breaks, one per construct. So in this case, if there's any construct that I either want to add or replace with, as I did not originally include cues to action, but again, if I use the Likert type scale by Hayes-Lips and use that to create a self-efficacy one, then that would be applied just as well. So that's what I put here, is that I would model those questions and the type of ratings based on that scale. All right, regarding the YPAS from Harada. Again, older adults, 60 to 86 years old. The way that is calculated is basically a summary index for different types of activities. They fit into 5 different domains of activity, but these calculations are based on frequency times duration times weight. So the scale or the instrument asks for each of that information, and it divides it up by a series of sections. In this case, not all of this instrument is applicable to this lesson evaluation. It would be taking or extracting just a couple of, 2 or 3 questions from that survey, as it is a pretty long survey, as I mentioned. And then each weight is then based on the relative intensity of each type of activity. So in this case, being vigorous activity has the most weight, leisure walking, moving on feet, standing on weight, and sitting on weight, or sitting weight, I should say. And vigorous being, as defined by federal guidelines as to if you can have a conversation, then it's not vigorous. But if you're completely out of breath, then it's too intense. So something in between. It can be moderate vigorous, but in this case, they just call it vigorous. Also, the Y-pass is measuring overall activity levels. So a low weight for sitting can result in a lower summary index, but a higher risk of disease or disability. So basically that's saying that if you sit for long periods of time, you're higher at risk for either disease or disability, which were outcomes from the research in terms of a lack of, or actually having a sedentary lifestyle with a lack of physical activity. The Y-pass results are adjusted seasonally so that it doesn't get skewed if the seasons affect the type of activities that elderly folks can do outside or indoors as well. All right, finally, the communication, reporting, and evaluation management. So I put all these together here because essentially a report will be provided to the stakeholders that would reflect the contents of this presentation in terms of the topics of the agenda that we've covered here, with an executive summary. I did want to caveat that in this particular lesson that was had, there were no data that was collected. There was less participants than anticipated. Out of 20, it was about 6 to 12, and then about half of those also were mobile, as I mentioned, compared to that they were targeted to be all mobile. And then also the questionnaires, so to speak, the activity surveys that I used for the lesson were a survey of hands, so they weren't written down. But overall, they participated less than I had expected as well anyways. So future lessons in this case would address that by having questionnaires ready for participants based on the specifics that I've covered here for existing instruments, so no need to reinvent the wheel. And also, each of these instruments, when the studies use them, they always provide the reliability and validity estimates. So, basically, these are high quality instruments. So future lessons would have those. And then the Sunrise staff has requested for this lesson to be repeated, perhaps monthly. So if that's possible, additional opportunities could be available to gather that data. It could be that it's repeated in different locations, not just the one in Montgomery Village. So that would be interesting to see if, in terms of the outcomes, if it varies depending on location, or if it's not just one educator providing the lesson, if it varies by educator and approach or style. And then finally, the stakeholders should be interviewed to determine their communication protocols, how they would like the report to be provided or delivered, and what method. and so forth. So they may want it just electronically, they may want it printed, they may want it both. They may want some of it or just parts of it. So at the end of the day, the report is for the stakeholders. So it is up to them in terms of what they want to see, and being able to communicate the information in a way that is the language that makes sense to them in terms of their decision making, for what they need to do and whether to decide to keep funding the lesson itself. So again, because there is no data, the report would not include data per se, but future reports would. So. Finally, I have a little surprise, and that's the end of my presentation, but this was one video that I wanted to let you all know about, and I found it in Infinity House magazine. It's also on Facebook, which is what this links to. You may have seen this already, but joven desde 1934, so young since 1934, and if you guys have a chance to watch this video, it's a fantastic video, and it inspired everybody in the room, so they were all, it had the intended effect, and they were all kind of set up and perked up, and were really in admiration of this lady you see here. So I won't spoil it for you, but please check it out, and let me know what you think. All right, thanks. So that's it from this lesson, and appreciate you guys watching. Bye-bye. Hello, everyone. This is